Wide-field, piecemeal, cold snare polypectomy of large, sessile serrated polyps without a submucosal injection is safe. Introduction. Sessile serrated polyps, SSPs, are important precursor lesions for colorectal cancer. They may remain indolent for many years, but once they develop dysplasia, they are high-risk lesions for transformation to colorectal cancer. Endoscopic mucosal resection, EMR, offers a safe and effective method to resect large, greater than or equal to 10 millimeters, SSPs, but exposes patients to the risks of diathermy, including post-EMR bleeding, which may occur in up to 10% of procedures in the right colon, and is likely due to unintended thermal injury to submucosal tissue and vessels. While these risks are small and certainly significantly lower than the risks of surgery, they are resource-intensive when they occur. Cold snare polypectomy, CSP, is the first-line treatment for colorectal polyps less than or equal to 10 millimeters, owing to its efficacy, precision, and excellent adverse event profile. Extension of this technique to piecemeal resection of larger lesions using a submucosal cushion has been described in small retrospective series. Large SSPs have a lower risk for recurrence and dysplasia than conventional adenomas. They are therefore low risk for the development of submucosal invasive cancer and potentially suited to a piecemeal technique with a low risk of complications. The authors sought to systematically examine the safety of piecemeal cold snare polypectomy, PCSP, without the use of a submucosal cushion for large SSPs. Background and study aims. Large series suggest endoscopic mucosal resection is safe and effective for the removal of large, greater than or equal to 10 millimeters, sessile serrated polyps, SSPs, but it exposes the patient to the risks of electrocautery, including delayed bleeding. The authors examined the feasibility and safety of piecemeal cold snare polypectomy, PCSP, for the resection of large SSPs. Methods. Sequential large SSPs, 10 to 35 millimeters, without endoscopic evidence of dysplasia referred over 12 months to a tertiary endoscopy center, were considered for PCSP. A thin wire snare was used in all cases. Submucosal injection was not performed. High-definition imaging of the defect margin was used to ensure the absence of residual serrated tissue. Adverse events were assessed at 2 weeks, and surveillance was planned for between 6 and 12 months. Results. 41 SSPs were completely removed by PCSP in 34 patients. The median SSP size was 15 millimeters, interquartile range IQR 14.5 to 20 millimeters, range 10 to 35 millimeters. The median procedure duration was 4.5 minutes, IQR 1.4 to 6.3 minutes. There was no evidence of perforation or significant intraprocedural bleeding. At 2-week follow-up, there were no significant adverse events, including delayed bleeding and post-polypectomy syndrome. First follow-up has been undertaken for 15 of 41 lesions at a median of 6 months with no evidence of recurrence. Conclusion. There is potential for PCSP to become the standard of care for non-dysplastic large SSPs. This could reduce the burden of removing SSPs on patients and healthcare systems, particularly by avoidance of delayed bleeding.